Hello students, my name is Robert Szymczak. I'm a specialist in emergency medicine. I work at Department of Emergency Medicine at the Medical University of Gdańsk and also in a helicopter emergency medical service in Gdańsk. During this seminar, I'm going to cover the subject concerning life-threatening conditions in trauma patient. I'm going to base this seminar on 2015 ERC, European Resuscitation Council guidelines concerning traumatic cardiac arrest of the trauma patient and the prevention methods of traumatic cardiac arrest. So I'm going to go through this algorithm, which maybe seems complicated, but when you will go through it step by step, it will become clear for you. So you have to realize that when the patient will go into the cardiac arrest due to trauma, it is connected with very, very high mortality. And the survival rates of patients with after planned trauma having traumatic cardiac arrest is around 3%. And the same goes to patients after penetrating trauma having traumatic cardiac arrest. They have their survival rate around 4%. And only, let's say, less than 2% of patients will leave the hospital with good neurological outcome. What does it mean to us? It means that we have to do everything in the pre-hospital care and in hospital with everything with the trauma patient to prevent traumatic cardiac arrest. We should look for life-threatening conditions, diagnose them and treat them, because when the patient will go into the traumatic cardiac arrest, then the mortality is very high and the prognosis is very poor. Patients who have cardiac arrest due to trauma and have pulseless electrical activity on the monitor, they have potentially better chances of survival than the patients with asystole, for example. So the aim of the pre-hospital crews, so the paramedic and the doctor who work in the ambulance or helicopter, first of all is to prevent traumatic cardiac arrest. Then they should know, and we should know, you should know, that the time is life. So the patient has to arrive to the hospital as fast as possible. So you should concentrate only on the procedures that are life-saving in the pre-hospital stage of the therapy. When there is the traumatic cardiac arrest, the pre-hospital teams, they concentrate on restoring the spontaneous circulation, so that they analyze the reversible causes of the traumatic cardiac arrest and they try to treat it. When they decide to go to the hospital, the transfer has to be very efficient. So it has to be, let's say, fast. The decision of the hospital which to choose should be also fast and clear. And the important thing is the communication between the pre-hospital team and the hospital. It has to exist and it has to be logical and effective. And the patients in traumatic cardiac arrest, or the patient with life-threatening conditions due to trauma, are of the category treat and run. So use the most, let's say, only the life-saving intervention to treat the problem, and run as fast as possible to the hospital. In the history, there was a category load and go, but some pre-hospital crews treated it too directly, and they did not do much with the patient. So remember, treat the life-threatening condition, only life-saving interventions, and run to hospital, because the final treatment usually for trauma patient will be in the hospital. So let's imagine that you work in the pre-hospital crew and you arrive to a patient after trauma. So first of all, you have to answer yourself the question, does the patient has a traumatic cardiac arrest? And it shouldn't take you more than 10 seconds to orientate yourself if the patient is in the cardiac arrest or no. How we, let's say, diagnose the cardiac arrest? Generally, when you've got an unconscious patient who is not breathing and you do not feel the pulse at the carotid artery, you diagnose the cardiac arrest. Remember that certain amount of trauma patients, especially in the, let's say, autumn and winter months, might be in hypothermia. So if you suspect hypothermia, then spend around 60 seconds for searching for the pulse at the carotid artery. And during those 10 seconds of the initial assessment, you gather a lot of information if you know what you should search for. So first of all, overall impression. So you see how the trauma looks like. You can see what was the mechanism of injury. You can see if the patient is bleeding, what color of the skin is of the patient, is he pale or cyanotic. You can observe some major traumas, some amputations. So generally some information is getting to you. So when you get to the patient, you try to establish the contact, and simultaneously I would recommend to check for a pulse at the carotid artery and check the pulse at the radial arteries. It's quite important to put your fingers on the radial pulse, because that's the good marker of shock or not shock. If you feel good pulse at the radial artery, it means that the patient has a systolic blood pressure equal of 80. So if you feel good pulses, good distal pulses, it means that the patient is not in shock. But if you feel weak pulses or no pulses at the peripherium, and in the same time you feel pulse, high frequency pulse at the carotid artery, you know that the patient is in shock. So you do not need to have a monitor to diagnose a shock in the trauma patient. You should assess the conscious level using the simple scale at the beginning, like AVPU. So is the patient alert, or does the patient react to voice, or does the patient only react to pain, or is unresponsive? Assess the airways if they are clear, if they are patent. Assess the breathing if the patient is breathing at all, and assess the circulation, checking the carotid pulse. So after this, let's say 10 seconds of initial assessment, you should be able to answer the question if the patient is in traumatic cardiac arrest or not. So if there is no cardiac arrest, then the next step is more precise ABCDE examination and taking the history using the sample algorithm. If the patient is in cardiac arrest due to trauma, then first of all you have to start the resuscitation. So we have to start the chest compressions, you have to use the monitor to assess the rhythm and decide if you need to defibrillate or not defibrillate the patient, and establish the airways, so secure the airways, start the ventilation, monitor the patient, put IV, and if all those things you organize, then as a doctor you should think about reversible causes of the cardiac arrest. So you should, as a matter of fact, take the history from some witnesses or the family of the patient, and examine the patient using the algorithm ABCDE to look for the reversible cause of the cardiac arrest, so for age and for T's. And the most important causes of traumatic cardiac arrest are hypovolemia, so hemorrhagic shock, hypoxia, tension pneumothorax, and cardiac tamponade. So just to remember you the sample algorithm, which is taking the history from the patient or family or witnesses. So S is for symptoms. So let's say the pain, where is the pain, what's the main problem of the patient. Then the allergies, especially allergies to medications. Then the medications that the patient takes and the past medical history. You might get some important clues from those questions. Then the last L goes for lunch or last meal. It's especially important when you would decide to secure the airways of the patient, because if the patient is with the full stomach, then you have to do it quite quickly. And that's also the important information for the anesthesiologists and surgeons if the patient will have to be operated. And then E goes for event leading to a problem or mechanism of injury. So it's quite important to think about the mechanism of injury. For example, when you've got the driver and there was the crash of two cars, and it was, let's say, the side crash from the side of the driver, then you would look for the injuries of the left side of the body, for example. So it's quite important to let's say think about the mechanism of injury. When it goes to the ABCD approach, in every letter you have to ask yourself a question. So when it comes to A stands for airways. So you should ask yourself the question if the airways of the patient are patent clear. So if the patient is talking to you, the airways are clear, but if the patient is, for example, unconscious, then there is the risk of obstruction. So the second question is there any danger of obstruction which exists especially among patients with low level of consciousness, or patient with the facial head trauma, patient with burning injury of the airways. So that's the first stage, airways. Assess the airways. And it's quite good to communicate with your team during this assessment and, let's say, making some short summary after each letter, just to let your team know about what is going on in your head and, for example, what you plan. If you would say that the airways are a danger of obstruction, probably you would tell one of your teammates to prepare, let's say, the intubation set, for example. Then the B, breathing. So assess breathing, assess if the patient is breathing, what's the frequency of breathing, assess the saturation, any exertion during breathing, and decide or diagnose if the patient is in respiratory failure or not. Does the patient need oxygen therapy, or maybe the patient needs to be helped with ventilation, let's say backmask ventilation or ventilator. So this goes to B, breathing. C is for circulation, and so you should assess circulation, so heart rate, blood pressure, pulses, and decide if the patient is in shock. If the patient is in shock, then you should ask yourself a question: what kind of shock is it? And after that you can start the treatment, knowing what kind of shock is it, because not every shock will be helped with fluids, for example. Then D goes for the level of consciousness. So assess it using AVPU scale or GCS. If there's suspicion of spinal cord injury and it exists in every trauma patient, you should perform a neurological examination, so check if there is if there is movement of legs, upper limbs, if there is sensation in lower limbs, upper limbs, trunk. So at least perform some mini neurological examination of the patient. In case of decreased conscious level of the patient, every time check glycemia, and every time check the temperature, and check the deep temperature using, for example, nasogastric tube with the probe, temperature probe, or using, let's say, also nasogastric tube with the probe inserted per rectum. And expulsion, it states for head-to-toe examination, so checking, palpating head, neck, chest, abdomen, pelvis, limbs, back, buttocks, so all parts of the body. So after performing this examination, you should make the small summary to your team, and after taking the sample, history and ABCDE examination, you should be able to at least decide which system has a problem. If there's a problem with airways, or maybe there's only problem with B, breathing, or maybe patient is in shock, and that's one of the problems of the patient. It's quite important to make a summary to your team. You should treat the trauma patient as some kind of, let's say, puzzle question, detective question. There is probably some killer inside the patient, and through the sample algorithm and ABCD algorithm, you gather informations, and you should gather as much as possible information through those two examinations. And after gathering those informations, you should be able to combine them to make the initial diagnosis of the problem of the patient and state if there is any life-threatening condition or not.